Welcome to the episode. I'm Dr. Armin Feldman, and as always, I'm here with my friend, colleague, and partner in Physicians Legal Consultants, Dr. Mike Bummer.
Hi, Armin, and hello to our listeners. We are thrilled to be here for our 50th episode. And
Yes, very exciting, huh?
yeah, a lot to celebrate. We've had a lot of fun doing this, and we just want to keep growing, building on it. And in that spirit, the surprise has already been spoiled if you're tuning in on YouTube because you're going to see a third person here today. And we're just again super excited to have a special guest. And I'll let you. Well, I should also mention we always start these and we say, hey, if you have a comment, some feedback, if you have a question for our guest, for us, you can email us at comments@physicianshelpingattorneys.com, and certainly find us on LinkedIn. Wherever you're listening to your podcast, go ahead and hit that follow or subscribe button. And without further ado, Armin, why don't you introduce our guest here?
Okay. For our loyal listeners, you have already heard this person. And for our new listeners, I'd like to introduce Dr. David Grundy. And David is a board certified emergency room physician. He's had in 2 tours as an Army major with combat experience. He is currently a practicing uh, uh, clinician and lecturer, very respected lecturer, and former assistant professor of emergency room medicine. David is also an absolutely great medical legal consultant. I am thrilled and proud to say that he went through the training program that I have, and he does just a fantastic job. He is so good at this. And I think Mike and I are both really pleased to say he's also a good friend. So, David, we talked about David doing a case today. So, let me introduce Dr. David Grundy.
Thanks, Armin. I really appreciate that warm introduction. I'm blushing a little bit here. Yeah, I've known Armin since I think 2018, and he really was the inspiration for me to get into this field that augments my clinical practice of doing the medical legal consulting, and it's just been fantastic. I mean, I like the bread and butter stuff, but we've had some real kind of Sherlock Holmes kind of cases that Armin has been in consultation with me about, and I love everything about this business. So thanks for that introduction. It's been great, and I'm looking forward to doing a lot more work with you.
Yeah, well, thank you. And you're right, David, that the bread and butter stuff we do, auto crashes and so forth,
Sure.
it's really fascinating work. Mike and I have talked about how much we love working with our attorney clients. But what you said is also true, is that it's great on those cases where we get to be Sherlock Holmes.
Absolutely. And, I think I don't know if you remember this, but the whole notion was here's a way we get to do well by doing good. I mean, it's really been invaluable to me to think about connecting with the client, and I think we've been able to both get justice and also, make some deserving people whole. So, been
Absolutely.
great.
So you've got a case you're going to talk about?
I do, Armin. So, actually, we were talking about this previously. I think it was a couple of months ago. And I think in our trade, all three of us have run into a question from an attorney client where essentially, when you boil it down, they're asking, do you have a crystal ball? I mean, obviously, one of the big things that we're looking for is future medical costs. And, that's a big aspect of what you're going to put in. Our work product would be appended to your demand letter. And we need to really be solid and say that, we have good evidence to show that these costs will accrue. And so, like a classic example that I ran into a couple of times, I've had an attorney ask me, okay, I've had a young man, let's say a young person has had a splenectomy from trauma. And they say, what's the future costs of a splenectomy? So there are complications that you can have following a splenectomy. Essentially this syndrome of overwhelming sepsis, it really can be life altering. but I don't know how to put a dollar amount on that, right? So
Right.
it's very challenging to do. And
Right.
if I can't do that in a way that would satisfy a court or opposing counsel, I just can't put it.
Right. Well,
However,
I lost my crystal ball a while back. It rolled
they do,
down.
yeah, me too, me too, me too. I had a
Yeah,
magic 8 ball for a while, but that, I lost that as well. So,
yeah,
so
rolled down a hill. So I'm really excited to hear what you have to say about how
exactly.
you do this.
And Mike, I'm sure you've run into these things too, right? This question, it's like, okay, there is some probability that a feared complication will occur connected to the injury that may be a matter of a tort, but we just can't assign a probability, right?
That's exactly right. I even have frequently cases that involve older individuals in car crashes who seemingly up front do not have dramatic musculoskeletal injuries or didn't have major surgery. But the literature, and we both know, these people generally then go on to have significant issues later in life because of all of the various injuries that occur that are kind of more subtle. And there's literature to support that. And I often build that into my future medical care and costs because I know that people will not necessarily only use the sequelae of their health care from an injury in that first 6 to 12 months, but it often, especially in older individuals, will be another decade or two of suffering from the effects of that injury.
Yeah, let me
Exactly.
throw one in too. That
Absolutely.
there's very good literature regarding with people that get a mild traumatic brain injury. They're more susceptible in later life to a whole variety of completely unrelated conditions, and it's pretty well studied.
Absolutely. And so that's exactly. So that's the class of things that we're talking about. And obviously, TBI is this whole world unto itself. And we could talk for hours about that. But I started thinking kind of almost in a more conceptual way, how can I make a really solid claim about something that might happen? And so every time I talk to my attorney clients, I preface it by saying, I don't want to insult anyone here because some of you know more medicine than my interns, and you could probably come pull a shift with me today. But some of you, this may be the first time you're hearing about certain injury patterns. And so I wanted to introduce this notion of reversing the causal chain. Every attorney knows if A leads to B leads to C, we can tie that together and, we can ask for the person to be made whole. But what if we could turn that around? So let me give you an example. I had a case of a young man. He was 24, 25, I believe, operating a motorcycle safely and at the speed limit as he was proceeding down a city street at just under the speed limit. Actually, there were two city vehicles stacked up, and a truck and a tractor, like a small dozer or something, suddenly pulled out from behind the truck and clipped this kid. So he had a terrible fracture, very obvious fracture of his right lower leg. It was deformed. He had a head strike, but nothing much came of that. But he did have an open fracture of his two bone fracture of his lower leg. So he was
Can I
taking, yes,
So
sir.
an open fracture, so it was bone was coming through the skin.
Yeah, that's right. So his insides were on the outsides. We don't like that,
Right.
So right. So that is a fracture that we would call comminuted. So it's in multiple pieces and it's open. And actually, these are great things for the attorney clients out there or the attorneys watching this. There's so many of these little buzzwords that you want to pick up on. Comminution means it's broken into lots of pieces. Open is obviously worse than closed. He also had a vascular injury, so his posterior tibial artery was injured in the course of this fracture. So, he had to have essentially a repair done of the artery and expeditiously fix the two bone fracture. So he needed hardware, intramedullary rod put into the tibia. So far, so good. The day after, they wanted to surveil the vascular injury and they went and did an MRI. That is to say, they didn't do it prior to the surgery, they did it after. And they found that in addition to the long bone fracture, which was in a bunch of pieces and it had a skin defect, in addition to that, he also had what's called a tibial plateau fracture. So we'll kind of talk about that in some detail. Have you guys seen some of these cases? Pedestrians
Yeah.
struck will get it, motorcyclists, that kind of falls sometimes from a height. Yeah.
Mm-hmm.
So the situation that they saw was essentially the top part of the tibia was impacted. It was kind of crushed in a bit, and this can be a very subtle radiographic finding too. And we're not really talking in like a med mal sense here, but it's an easy one to miss, and it has a significant consequence. So if you break the shaft of your femur and it's appropriately repaired, sure, you might have some complications from that, postoperative pain. Some people even need the metalware removed even years later. But we don't really know what the statistical chance of that is, and we know it's not above 51%.
Mm.
However, tibial plateau fractures, it turns out that with very careful attention to the medical literature, you can find subsets of these that do have a known rate of severe post traumatic arthritis, and it's above 51%. So in this case, so the special factors that he had was the violence of the injury, the comminution, the skin defect. There were some other individual factors that he had. And then we go back to the literature. I found a Danish study actually that shows with these factors, you've got about an 80% chance of needing a total knee joint replacement.
Wow.
So that's the reversal of the causal chain. I mean, typically you would say we have A, we have B, and A are related. It's 51% chance. Now I say I have A. What's the chance down the road of B? And I assert if that's over that magic 51% bar, that's something that you can ask for. And I've done about 3 cases that are kind of similar conceptual approach, gotten very satisfactory settlements in each case. So
So
that's
when
the
you say you're reverse engineering it, what you're saying is that you're looking ahead and to see what possible problems could this injured person have on the basis of the acute injury that we're commenting and consulting on, and then trying to make some kind of determination as to the probability of that and what treatment might be needed. Is that what you're saying?
That's exactly right, Armin. And I would assert that there are several different, we can talk about these other entities as well, but there are several fracture patterns and soft tissue injuries where you can do exactly this kind of analysis. Now, and that's why, I think it's worthwhile for an attorney to talk to you guys, talk to me or one of our colleagues, because there is, I think, some real nuance here. You have to have a real deep understanding of the literature. And just because you want it to be there doesn't mean it's there. I mean, sometimes you look at it and you say, what's the chance of post-traumatic arthritis in this injury? And it's 12% or 2%.
Right.
I don't think I would ask for that as a future medical, but sometimes it's there, so you go for it.
Yeah, and I think our attorney, it's our experience, I'm sure it's yours, that our attorney clients are just as happy to hear, well, there wouldn't be anything here. The chances are quite low, and it would, we wouldn't quite say it in these words, but it would be kind of a waste of your time and money and the clients to try to go down that rabbit hole. And that's a great thing for them to know.
A really black and white example of this is, personally, we had a dog that had ruptured its ACL on the one side, and I thought of this because the surgery to repair it in dogs is becoming a tibial plateau surgery, a TPLO, where they actually reconstruct the knee so it no longer needs the ACL. But what they told us, and why this is more relevant, is they said, unfortunately, sir, there's an 80% chance the other ACL is going to need to be done at some point. And we know this based on literature because the dog moves a little differently, strains the other ACL. So just don't be surprised if you're back in here within 3 years needing to get the other one done. And I think that highlights exactly what you're talking about. This surgeon knew, and the literature supports, that even though that one injury, let's say this is your case where that fracture or that comminution occurred at the top of the tibia, that surgeon might know that, arthritis is some great percentage later, and it would be an injustice and really a missed cost to include in that negotiation, because that person is most certainly going, more likely than not, going to be dealing with the repercussions of that injury.
That's super well stated, Mike. And there's another ancillary benefit to this. So, I like to talk to my clients. Well, yeah, first, that de-risking thing that you're talking about, Armin, is fantastic. I mean, if I can spend an hour thinking about this and tell you this is a nothing burger, this is implausible, and you don't spend 10 billable hours on it,
Right.
huge win, right? But yeah, I do like to talk to my clients at least twice, right? And so this kid, this young man, I did the analysis, and I find, there's a good chance you're going to need a total knee joint replacement, even though you're in your 20s. I
Mm-hmm.
called him and I talked to him. I mean, I know I'm not his treating physician, but we've got rapport. I like to, hear all their concerns. And it's now 10 months after the injury, and lo and behold, he really does have a lot of arthritis pain already. So I can kind
Wow.
of prep him for this notion. My patients typically, generally in an older age range, they say about getting these arthroplasties. I wish I'd done that 5 years ago, and
Mm.
not had the 5 years of pain, because it's really tons of functional improvement. So I think that was sobering to the man, but also it helped him frame what was going to happen next and kind of wrap his head around it. So, and of course, we were able to make him whole as far as the cost goes. So it made things a lot easier for this guy who might have just suffered for a decade, and then he still would have needed the total knee. So I think it was a win in that way also.
Did you get follow up on these, David, from the attorneys on the final settlements or negotiated terms of these
These I
cases?
did, and suffice to say, the numbers were satisfactory to everyone. So,
Mm.
So I think I interrupted your role there,
by
David.
all
So,
means, yeah, bring it.
uh, but go on about. So you started looking at what are the potential problems that this uh, client of the attorney is going to face. Can you follow up?
Well, so in this guy, what he's going to face is a couple of things. He's going to have crippling, worsening pain. I mean, osteoarthritis, unfortunately, if it's from micro trauma and wear and tear, or if it's from a traumatic injury like this, it's a one-way street, right? And so, of course, there are things that can be done, like Synvisc injections and analgesia. I don't want this guy to become an opiate addict. I think that there are a lot of things we could worry about, but the thing that we can certainly prove from the literature is his chance of needing a total joint replacement. And that's the big one. And I would say, in terms of future costs, it's the big one there too. I
Mhm.
mean, obviously, it's an expensive thing to have done, and there's aftercare and PT and a lot else that needs to happen. So that's the big one. There's a couple other entities that are similar to this that might be worth discussing as well.
Sure. Let me ask you a question though.
Sure.
When you wrote your report, did you put a percentage on the possibility for the total knee replacement?
I did. I put an exact number, well, a range, which I extracted from this Danish study. So I think that's for the attorneys out there. If you're talking to a consulting physician, I mean, anyone you hire should be pretty good at looking through the medical literature in a nuanced way. But it does make all the difference. As you know, papers range. In fact, I got one paper that said the chance of a total knee joint replacement is 18 to 80%. I'm like,
Yeah,
what the heck
that
do I
helps.
do with that? It's this massive range.
Yeah.
But we can support it with other pieces of literature that show you're pushed to the higher end of the range if X, Y, and Z, if there are other factors such as he had high energy, the concomitant severe fracture, the skin injury, the vascular injury. So that's
So,
how we accomplished it in this case.
so in your report, what range did you put?
I put simply that it exceeds 51%, and I expect it's in the 75% range.
Okay. And
So
you
that was
had
that was my
evidence
crystal ball. That
that
was as close as I could get, right? Murky crystal ball, but it did satisfy the opposing counsel, and they just said no mas and settled right then.
great. So that was negotiated into the settlement,
That's right.
uh, and they didn't really opposing counsel really didn't argue much about that.
Nothing further. Yep.
Huh.
I think they had been kind of sending some signals that they might have wanted to litigate before my attorney client came to me. But then with that report, it made straight the way. It really did. It was easy after that. So,
Yeah.
like Armin, I think one of your phrases, that's the way it's supposed to work. It was good.
Right.
It was a good day at the office, good week.
Yeah. So you said you had a couple of other things
Well,
related.
yeah, I'd like to think about this as, a general method, maybe a conceptual tool that certainly the attorneys can use on their own, or for the other, medical legal consulting physicians out there, something to think about. When you're analyzing these cases of traumatic injuries, let's say, but it could be anything. I mean, it could be anything that amounts to a tort. I can imagine toxicology cases like this. What you
Mhm.
want to ask is, what are the known complications? In medicine, we call this, it's sort of similar to like expanding your differential diagnosis. Instead of narrowing, broadening kind of your ambit, right? And you generate a list, and some of it might be really, really weird. Like, this person may have post-traumatic fibromyalgia. We've done cases like that. It's real, right? If they have it, they have it.
Right.
Typically, we would have a patient who has that entity, and then we say, can we ascribe it, to the injury in the past, or who has that outcome? Now we want to do it the other way around. We say they've had this severe injury. What are the chances of X, Y, or Z? So here's some things I'd have people look out for.
Mhm.
Two came to mind immediately, and they're both injuries about the wrist, right? So, um, may I rant a little bit about scaphoid fractures and what a big deal this is?
Please go ahead.
Everybody's heard of scaphoid fracture. So the human wrist, what an amazing structure, but it's kind of fragile too. So right at the base of the thumb is a bone called the scaphoid, and it bears the load of the thumb, and it allows this glide in multiple axes and so on and so forth. I mean, it's critical. It's also critical to the stability of the wrist because it articulates with the distal radius, right? The wrist bone here. So here's an acronym you guys should look for in the charts. FOOSH, FOOSH. That's a fall on the outstretched hand, right? Many times an x-ray is obtained, the wrist is swollen, it's tender, and the x-ray is negative. It doesn't, so the injury is what we call radiographically occult. But that bone is
Hidden.
broken, and this can lead to some really awful consequences. Weirdly, most tissue in your body, the blood supply comes from, nearer the heart, and then it goes out to that bit of tissue, thumb, whatever. The scaphoid is unique in that this vessel comes out and it wraps around, and it comes in from distal, from further away. So when you break that bone, there's a very good chance that the bone will die. It's called osteonecrosis. And then this leads to a chronically unstable wrist, a need for surgery, a very complex surgery, a vascularized bone graft. So, what I would say in scaphoid fractures, even if they're recognized and treated perfectly initially with immobilization or what have you, it matters exactly where the bone breaks.
Mhm.
If it breaks towards the outer portion, the distal fifth, maybe 10% of these will need that complex surgery. Down towards the proximal fifth, it's as much as 85%.
Wow.
So we're not talking medical malpractice here necessarily, although it is a bad thing to miss a scaphoid fracture. But even if it's treated perfectly, by careful analysis of what the fracture actually was, where the fracture plane was, you could say this man has more than a 51% chance, or woman, more than a 51% chance of having severe crippling osteonecrosis and pain and need for a vascularized bone graft. Now, we don't like to crassly talk dollars and cents all the time, but I will say that if you're getting a vascularized bone graft of your scaphoid, mate, you're talking $500,000. I mean, there's just so much that goes into it. It's a very complex procedure. And if you can show that they're very likely to need it, ask for it up front, might as well. So that's the approach I would say.
A
Yeah.
great
And
example, David. Thanks.
yeah. And those outstretched arm injuries, they're so common, right?
Yeah.
All the time, yeah. But
I kind of
there's
think of snowboarding too out west, and everyone who
absolutely.
falls back or anyone who's falls, the first thing you do is
Yes.
that's why it's foosh.
Right.
Yeah, right. Same.
Exactly that.
Yeah.
So yeah, I mean that's one. There's another pattern, another type of wrist fracture. This is not in the carpus, the small bones, but in the distal radius. Sometimes also from a foosh, you can get this injury called a die punch injury, and so the wrist bones essentially like kind of pile drive into the radius, and they crush the bone into itself. They kind of impact it, right? And so for that to have happened, there has to be enough injury that it just crushes the cartilage in there. So this is
Mm.
another one where it may look relatively trivial, and it may even be treated, quote, appropriately, but then, based on certain patterns that you might see on X-ray or advanced imaging, you can say, this guy's going to need, some procedure for severe destructive arthritis. So
Later on that they're going
later
to need.
on, yeah, exactly. I mean, you're talking maybe 5 years down the road or thereabouts, but it's coming. So you kind of just ask for that up front.
Yeah. Well, those are great examples. And I love this idea, David, of reverse engineering, that we've got to look into not only what's happening immediately, but for high percentage chances of something unfortunate, bad medically to happen later. It's a
Exactly.
great thing you've done in terms of putting that together.
It's the next best thing to a crystal ball. But I even teach my students this. Honestly, Armin, I thank you for getting me into this field. It does enrich my clinical practice to a very large extent. I find I'm reading way more literature than I did 10 years ago, which is
Yeah, right.
cool. But another thing I love about the field. But I will say that you scan the human body, and it's like a heat map. It's like a pediatric elbow. Like, oh my gosh, there's so much that could go wrong. Mid shaft radius fracture. Nah, that's easy. You know what I mean? And so like
Yeah.
things kind of scale differently, but there are certain parts of the body where you can have these occult injuries, or you can have things with known complications. I would say vascular stuff is like that. Maybe you can show there's a 51% chance this person will need a skin graft down the way. We've done
Yeah.
this also with burn injuries. The person
Yeah.
has had an initial revision, but their surgeon says there's a 60 to 70% chance they'll need a redo flap. Which
Well,
of course,
maybe we'll do the burn injuries on a separate
sure,
episode. But yeah, thank you so much, David. We
absolutely.
just love having you on, and you just do such a great job at explaining these things.
I really
So,
appreciate that. And thanks for
yeah.
having me.
Yeah. So, Mike, you want to just
No, just again, kudos and thank you again to Dr. Grundy. He's become a close friend and a consultative resource for me. I'm so thankful and always appreciative of his insight. Everyone listening, it's pretty obvious to tell how analytical and how intelligent he approaches these things. So, again, just kudos and thank you so much, David.
All
right?
right. Thanks, both of you. It's great talking to you today.
Yeah. So, if you are an attorney and you have a case like David described, or any kind of a case, and you'd like to run it by us, please send us an email at comments@physicianshelpingattorneys.com. And as Mike said, please, if you're listening on the audio, follow us. And if you're watching on YouTube, please make sure that you're following us there and you're clicking the bell button so you get notified of future episodes. And as always, we look forward to having you on the next episode.